Visit the YouTube channel and subscribe for more oncology videos.
Retroperitoneum is a closed compartment bounded anteriorly by parietal peritoneum and posteriorly by transversalis fascia and vertebra. It is divided into perirenal space, consisting of kidney, adrenal, renal vessels, renal pelvis and proximal ureter. Anterior perirenal space, consisting of pancreas, duodenum, colon. Posterior perirenal compartment, posterior to kidney, consisting mainly of fat. The most common sarcoma subtype arising in the retroperitoneum is liposarcoma. These tumors arise from perinephric and retroperitoneal fat cells. As they grow, they displace the viscera medially, progressively displacing them into the contralateral abdomen. Being mostly fat, they appear darker on CT as they provide little impedance to X-rays. However, if some area gets dedifferentiated, they develop change in texture and become more solid in that area, appearing lighter than rest tumor. 1/3 of liposarcoma are homogeneous, well-differentiated tumors. Approximately 2/3 are more aggressive heterogeneous tumors containing dedifferentiated components. Leiomyosarcomas develop from smooth muscle cells. In the retroperitoneum, they often arise from blood vessels such as renal vein, gonadal vein or inferior vena cava. These tumors have a high chances for distant spread. Retroperitoneal sarcoma are rarely symptomatic, hence they can be very large at presentation. Symptoms only tend to arise when tumors are large, causing compression of the adjacent viscera, invasion of other organs like kidney, adrenal, colon, ureter, intratumoral bleeding causing rapid enlargement and pain, and due to metastasis. Kidney is often encased or pushed by tumor anteromedially. Primary investigation is a computerized tomography scan with intravenous contrast of the thorax, abdomen and pelvis. Plain high-resolution CT scan of thorax is better in detecting lung mets than contrast-enhanced CT thorax. Lung is filled with air, hence appears black in plain CT without parenchymal visualization. Hence any pathology like cancer or consolidation in which there is solid area becomes visible on plain films. On contrast injection, whole parenchyma enhances, hence any small tumor can be missed, plus small enhancing lesions can be confused with cut surface of vessels with contrast. The utility of MRI imaging in retroperitoneal sarcoma is limited, but is particularly valuable in patients with pelvic disease, when CT is contraindicated like contrast allergy and pregnancy, and in tumors with indeterminate bone involvement on CT. PET scan provides information about distant metastasis not visible on CT scan. It tells about grade of tumor, as glucose metabolism have been shown to correlate with tumor grade. Identifying the areas of maximal glucose uptake can be used to target preoperative biopsy in areas of greatest uptake and therefore highest grade. In retroperitoneal lesions, main reasons to obtain a core needle biopsy are to exclude other malignant processes like lymphoma, germ cell tumor where chemotherapy is primary treatment rather than surgery. To identify chemosensitive pathology such as Ewing sarcoma, synovial sarcoma or GIST in which neoadjuvant treatment may be indicated to downsize the lesion, reduce its biological activity and potentially facilitate organ-preserving surgery and better oncological outcomes. Core needle biopsy should be performed under CT or USG guidance using a retroperitoneal approach, targeting the highest grade component of the tumor. Anterior approach is risky due to increases chances of bowel injury and bleeding. The primary modality of treatment for patients with retroperitoneal sarcoma is surgery. Tumor is removed with unblocked excision of non-critical structures, if needed to achieve R0 resection, like kidney, colon, ureter, adrenal. When is retroperitoneal sarcoma inoperable? When there is extension into spinal canal, vertebral body, bilateral renal vessels, celiac trunk, aortic wall involvement, portal vein, mesenteric root involvement. Adjuvant radiation has role in retroperitoneal sarcoma. Radiation can be given in pre-op or post-op setting. Pre-op radiation is preferred as large tumors displace bowel from radiation field, hence less side effects. Neoadjuvant chemotherapy has limited role in sarcoma. They are used for downstaging tumor in case of chemosensitive histology. So in case of non-metastatic retroperitoneal sarcoma, if surgery can be done with less morbidity, lesion is removed. However, if extensive resection is needed, with high morbidity expected, then in chemosensitive histology, neoadjuvant chemo can be given to downstage. In chemo-resistant histology, either pre-op radiation is given or extensive surgery is done. In inoperable sarcoma, chemo is given in case of chemosensitive histology, or else radiation is given to downsize and make tumor operable. If still tumor remains inoperable, then radiation is given, if not given before. Second-line systemic treatment is given. And then palliative treatment is started.
Visit the YouTube channel and subscribe for more oncology videos.